This is the first brown bag lunch of our academic calendar year because our brand new fellows have arrived, for those of you joining online. And how it works is we're going to have an hour with our fabulous speakers today, and then we're going to have some time to end for Q&A. So please continue eating. This is meant to be informal. Please do grab some snacks to that. For those of you joining online, if you'd like to know more, please log on to the Stanford Biodesign website. My email is on the posters. We're always happy to take feedback, take comments about suggestions on topics, and please do engage. This is meant to be conversational, not a lecture, and we're just really glad you're here. So today we have a really exciting speaker and talk, and I'm actually going to invite my colleague Krista Donaldson to introduce our speaker today. So Krista, you want to go ahead?
Yes, hi, I'm hidden in the computer. I assume you can all hear me. This is Krista Donaldson. I am the Director of Innovation to Impact at Biodesign, and I could not be more thrilled to introduce Dr. Lee Sanders. I'm sorry I'm not there in person. I'm quite far away, but again, here in spirit with all of you and very excited to hear. Dr. Lee Sanders is a general pediatrician and professor of pediatrics at Stanford, where he is the chief of division of general pediatrics. And he has joint appointments in more departments than I've ever seen a human have before. So Lee, we might have a few questions about that, but Department of Health Policy, Department of Epidemiology and Population Health, and the Friedman Spoley Institute for International Studies. And he also teaches in the what we call the Bio program here at Stanford, Human Biology, and at the D School, the Design, the Hasso Institute of Design. And that's actually, a little personal side note, is how I came to meet Lee. For those of you who are not familiar with the Bay Area Global Health Alliance, it's a very active global health consortium based here in the Bay Area, but global. But the chair of the board was Lee's college roommate at Harvard, Colin Boyle, who hopefully you will all meet. He's on the faculty at UC Berkeley. But I'm also on the board of the Bay Area Global Health Alliance. And when Colin found out I was doing health equity at Biodesign, he's like, you have to meet Lee. He's doing all these amazing things. And so Cyan and I have since met with him. And I'm going to read more of his formal bio, but just to say, like, he's a really leading thinker in social determinants of health, for those of you who are familiar with that, behavior change, health literacy, and a number of other areas. And what's very exciting to me is bringing all of these different areas together with medicine and design to improve the lives, particularly of children. So it's very exciting. So let me return to his formal bio. And then we'll kick it back to Lee. Sorry, Lee, I know. But when you're as talented as you are, we had to do it. Well, let me just mention a few things then. He's been running several really interesting federal studies. One is the Green Light study, which aims to assess the efficacy of low literacy multimodal interventions designed to prevent early childhood obesity. Another project is the Goalkeeper, and I don't know how much you'll be talking about some of these, Lee, but an AI-driven support for parent-provider coordination, and looking at health literacy to inform FDA guidance on medication for adolescents with chronic illness. So just to give you a smattering of his background, one thing that's also very interesting to me, Lee was also medical director of Children's Medical Services of South Florida, which is actually another area of overlap because I spent a year living in South Florida. But there, which I think is very interesting given the politics and everything, is that he coordinated care for over 10,000 low-income children with special needs. And he was medical director for Reach Out and Read Florida, a pediatric clinic-based program that provides books and early literacy promotion to more than 200,000 underserved children. So I'll stop there. Lee also teaches a class in the D School. I believe it is starting this quarter. Is that right? Yep. On health design and health equity, which I hope to be able to sit in on a little bit. So over to you, Lee, and the team there, and happy to see you all even by Zoom.
Well, Krista, thank you so much for that warm introduction. You know more about me than I know about me. And science. Well, I am truly honored and humbled to be here for, it sounds like, your kickoff of these brown bags for this fall. And I really want to get to know you guys through your questions. So please interrupt me. Cyan already knows she's required to interrupt me when we get to about the 15-minute mark, no matter where I am with my slides, so we can really dig deeper into conversation. It was very helpful, actually, Krista did that introduction. Some of the slides are covered. So, and then the other thing is, yeah, thank you for bringing up my college roommates. The best thing is, hold your roommates dear. Colin came back. My med school roommate is Daniel Kraft. Some of you might know, he's also like a futurist in medicine. And so a lot of the things that I do and interactions that I have that are cross-disciplinary are due to my roommates. So there you go. So let me see if we can get this going. Slides, got to get the tech working. So I always have to have a disclosure slide. So first of all, I do have funding from a number of federal agencies. I do consult for one AI health company, Metaloop, that's trying to create an interesting platform for clinical research using LLMs and other AI related technologies. I do feel privileged to be here and have had a privileged course in going through medical school and residency here and teaching at the University of Miami for several years. And my final disclosure is I'm very curious. So I'm going to be sharing things with you. I am very curious about each and every one of you in this room and what brings you here. I'm very grateful. I can't go through all the people here. These are people who, just smattering of people who've contributed to my work, colleagues and mentors, Health Literacy Lab, fellows, et cetera, and the Native people on whose ground we speak today. I don't normally do this, but yesterday around this time, I was speaking to Stanford undergrads, and they asked you to talk about yourself, your career. So that's why I was saying Kristen. But Science said I should talk about this as well. Where do I come from? I born in Philly, grew up in South Florida, the grandchild of Jewish immigrants from the Pale settlement that's in the middle there, and that's my two grandmothers. I often channel them. Very interesting backgrounds they have as immigrants, and they're holding my youngest daughter there, who's now 21. She was like, "It's great, Dad. You have me." So that's kind of some of my roots, and that's my baby photo there in the lower left-hand corner, sent away. And a few other things I try to figure out. What are the themes? What are the values that drive the work that I do? And I realize when I work with other folks, when I work with designers, when I co-design with families, I'm more and more interested in the way, a lot of we have shared values, but the values that we bring to what we do. And I realized, well, where does this justice come from? I don't know. I was a safety patrol. Anybody in elementary school here remember the safety patrols, the orange? Okay, yeah, the safety patrol. Maybe it comes from that. The compassion that I bring into my work, I think, has something to do with the respect for immigrant families that comes from my own immigrant experience. My wife herself is an immigrant from Eastern Europe, and I've served only immigrant families in South Florida and Northern California. So there's something of that. One thing that I've regrouped with, Krista mentioned my college roommate at that time. When we met, I was editing the Let's Go travel guides. Some of you might not know this, but it used to be you had to carry around a physical book when you traveled. You couldn't find where you went. So I edited the first travel guide for California and Hawaii that we had. And I've traveled quite a bit, like I'm sure a lot of you have, but with this sense of, what does it mean to be a tourist? What does it mean to go in different environments? What does it mean to navigate there appropriately? And I would say that's the most recurring theme in the work that I do, even the health literacy that I do. It's very much themed around navigation. And then finally, creativity. I said I'm a painter. I'm not really a painter. I'm sure many of you in this room are better artists than I am, but I do really enjoy painting and working with clay and doing ceramics. And I think that's in some ways what brought me to the D School to begin with. Chris also mentioned this before. I've worked with lots of different institutions. I did get my public health degree at Berkeley and really got some grounding in social epidemiology, which informs a lot of what my work. Also was mentored here by two great experts in health behavior, Tom Robinson in pediatrics, and our mutual mentor, Al Bandura. If you ever know him, he's the progenitor of social cognitive theory. I got to meet with him 3 or 4 times, not 3 or 4 days, 3 or 4 times over a couple of years. It really informs my thought about behavior change, which a lot of us are about if we're doing design work in healthcare. As a history major, I've done a lot of cross-sectional work in ethics and policy. We'll get into the health literacy in a second. And I'm very interested in this notion of complex care. What does that mean? I direct a complex primary care clinic. What do we mean by medically and socially complex patients? And I'm now a human-centered designer without any training. So full disclosure, how did I wind up at the D school? At the ripe old age of 49, which is very young. I went to Burning for the first time with my med school roommate. So for those of you who that went there, that's great. I'm just saying that because when I'm dressed like this, people are like, and I've been there many times since, but I came back liberated with a different view of how we can see one another and really listen to one another. And it was then that I lost the fear of teaching and the fear of design, and called up sort of a colleague of mine that I had met loosely through the D school, and asked her if we could launch a class together, and that's Jules Sherman. So these are some of my D school, we call them lead learners at the D school. One of the things that one of the agendas here is to continue to build bridges between this place and that place, the D school. So Jules and I taught a class and brought patients into the classroom. 17, and we did that for a few years, and these are the other folks, if you haven't met them before. Seamus Hart, who himself has a chronic illness and has taught many of my classes and directs a lot of the teaching over there. CJ, or Christine June, who's actually directing a medical center and has a lot of design experiences. David Jonko is both a physician and designer, and Joanne Chung. These are the creatives that I get to work with there. And I'll tell you a little bit, this is the frame story. I'll tell you a little bit about that story. We'll regroup about that, but that's what happened really in 2017, 7 years ago, and really has engendered my interest in design, and the overlap for me between design and healing is becoming more and more really clear and tactile. I want to help you guys tap into some of that. That's probably what brings you into this room. So I mentioned a little bit the other things that bring me into justice. Krista mentioned I work for the government, so that's an interesting way. You know, sometimes you can, by working for a public health agency, like the one I work with in Florida, and a similar one here in California that serves special needs kids. That challenges me to think about how we leverage government and the public coffers for justice. I am a trained physician. I see patients several days a week. I was in yesterday morning seeing the newborns all day on Monday. But I take my role also as a physician scientist very seriously. And although we have a lot of latitude in design to think about new things, I think it's really important to think rigorously about how we might test those designs in real world settings to really assess efficacy. But the final thing about me that Krista didn't mention that I wanted to share with you, which is a new thing, was that 1 year ago I became a patient, and we're all patients, but I became a patient in a very unexpected and somewhat life-altering way. Very healthy, like me. And I'm not going to ask you about your health experiences unless you want to talk about them later, but I'm very open about this. I was very healthy, biking 30, 40 miles a weekend, going all over Northern California things, and started getting what I thought was worsening gastroesophageal reflux, right? Talked to my PCP, long story short, went in for an endoscopy and woke up to a physician about half my age telling me that she saw a mass in my esophagus. I was pretty sure it was cancer. She told me what type of cancer. Then walked into a room with my wife. We Googled that type of cancer, the esophageal adenocarcinoma. And the first two things that came up on Google were 20% 2-year survival and palliative care. Thus began my journey over about a year from then to now. Next scans next week. Let you guys all breathe. I am now currently in remission after lots of chemo, radiation, and surgery, and great care here, but really experienced all parts of the healthcare system just through Stanford Health. Good, the bad, and the ugly. Now, I could not be a more VIP patient, right? I was trained here, I'm a leader here, I'm a physician here, and that kind of stuff. I saw it all. Some really good stuff. I saw some really bad stuff. And it sets my view and my awareness why I'm here and why we're here to try to design a better system. Because like I try to tell my undergraduate students, healthcare system is neither health nor caring, or very much in the system. All you need is the experience as a patient. If you haven't had that as a patient. So I've been researching that for 30 years, the patient experience, and then had the opportunity to live it. So smiling all the way through the chemo. I just want to share that because that's sort of a new experience. And I have patients of my own. So as Krista mentioned, as I mentioned before, I direct this complex care clinic. This is what we would call our average patient that I saw in care yesterday. That's actually a photo. You can tell because there are no gray hairs there. I think it was Miami. 4-year-old girl with a number of chronic conditions, largely from birth. These are legacy of birth conditions. In her short life, she's been on, she's currently on 4 chronic medications. She had been on more. She's been seen by 12 subspecialists across 3 health systems just in the first 4 years of her life. Her mother has a chronic illness, so does her sister, and she lives in multi-generational housing in a small 1-bedroom apartment with limited formal education and limited English proficiency. So like I said, our average patient, and this is what we call a care map. If you guys have done journey maps yet, up to that case, this is another way of thinking about journey mapping. This was not by this family, but it's one we often refer to because it gets the point across. Nice multicolors. That we asked parents to draw the map of what it looks like for them to meet the care needs of their child or their loved one in a given week or month. And there are a few things. Hopefully you can read the words there, so you can see, the patient and the family are in the center, as you might expect. And the one thing I would like to emphasize, particularly for the medical folks in the room, and I meant to ask this: how many people are providers? Went through all this great training. And from the perspective of most patients, that's really in that lower left-hand column. This is the blue, so that's where healthcare and they have the primary care and subspecialists, but includes dentists and pharmacists and so forth. The rest of what we need to navigate to meet our healthcare needs or the healthcare needs of a loved one are not that. In child health, they're often the school. In adult health, it could be the workplace, that's in red. Advocacy and information sources, recreation and community, social supports, developmental assessments, these other things that folks need to navigate. And in the context of that, and we'll talk a little bit more about the definition of health equity, but my lived experience, my day-to-day lived experience of health equity is taking that patient care experience, that patient map, through my prism of health equity to ask what kind of system do we need to meet everyone's health needs. That's my operational question that keeps me going. So here are three things I hope we can cover together. You can stop me at any point, challenge me, it's fine. I want to talk about some of the key challenges and definitions around health equity. Explore this area of health literacy that I've spent the better part of 3 decades exploring as originally not a design tool, but I really think it's a useful design lens on looking at health equity. And then finally, human-centered design itself. So first, a photograph. This is a photograph of where we are from above, roughly. Google Maps photograph enabled. What are your observations, first of all? What's your observation?
Very green around Stanford.
Very green around Stanford, excellent. And then what's that other area where it's not green?
I'm new to the US, but
Great.
I'm guessing like lower income.
Maybe a lower income area. Does anybody know what that?
East Palo Alto.
That's East Palo Alto. So actually this area has changed a lot. I've been in and out of here since 1990. It's the East Palo Alto, very traditionally low income area. A lot of that area is actually being gentrified for a lot of reasons, mainly Facebook, now Meta, which is nearby, just a little bit northwest, I guess, of East Palo Alto. So that's observations. We can make lots of general observations just by driving around where we live. But here's just one example of health equity. We can look at the life expectancy of folks who were born. So I mentioned on Monday, it was a very busy day in newborn nursery. I saw 26 to 30 babies and actually lost count, not just on my own, but the residents and so forth. They're all born there, phenomenal facility, get the same sort of care. But if that baby goes home to Menlo Park or Palo Alto, their life expectancy is roughly 80 years. If that baby goes home to East Palo Alto, their life expectancy is 62 years. So that's one statistical example, epidemiologic example of what we mean by health equity. What I want to explore a little bit with you is some of the mechanisms about that. Some of these other graphs, you've hopefully seen versions of this before. We look globally. We're experting global health and I. But, and these are just OECD countries, so relatively affluent countries. At the difference between the expenditure of on healthcare services per capita and life expectancy. And if you kind of see the United States, we spend a lot way out to the right, our life expectancy is lower in lots of other countries. Seen this before, we can talk a lot. We have health policy experts who can explain this better than I am. That's another way of looking at these expenses. You know, I sit in pediatrics, and one of the most durable markers of health or public health of a country is infant and child mortality. And we kind of don't think about this too much. Children dying, infants dying, but and it's much lower rate than it used to be certain years ago. But even there, you can see similar disparities. Lots more money spent on healthcare, lots worse child mortality right here in this country. And then even within this country. So I showed you kind of within or on the border of two counties, you know, East Palo Alto, Menlo Park, Palo Alto. But this is, you know, a national map. We're actually going to be doing, hopefully, NIH funds us, another version of this looking at child morbidity. But these are just differences in expected age of death or life expectancy based on what county you live in. And Robert Wood Johnson Foundation puts this out there. So as a result of this, we'll get to the zip code and the genetic code observation in a second. But as a result of this, you know, we can kind of feel and live in an inequitable society in terms of health outcomes. So what's health equity mean? There are lots of different definitions. This is some summary one that Robert Wood Johnson and that came out that Paula Braverman originally proposed. It's more of a US-centered health equity definition that everyone has a fair and just opportunity to be as healthy as possible. So you guys have seen some of this before, but again, can see this and how we act on this and how we understand the mechanisms, I think is what. But it has to do with the safety and nature of places in which our children can play and walk, we can eat, what our backyards and air quality look like. We send our kids to school, we live, where some of the most unfortunate among us are living right now. So as a result of this, there's been a lot of work on this, the construct of social determinants of health. As I mentioned before, I've done a lot of work on literacy determinants of health, food insecurity. Some of you might be interested in other areas, certainly at the overlaps between education and health. We have folks in our division, Department of Work on Intermittent Partner Violence, housing insecurity, et cetera. So that's a really important sort of public health approach, health equity. And here's another one. I often hear people say that the zip code is more important than your genetic code to determine your health outcomes. Who's heard that before? Right. I just gave you some visual documentation of that. And this is true. You know, I'm standing here as a card carrying. It's the only thing I got trained in epidemiology, right? So I can say this is based on lots of epidemiology and lots of controlled studies showing that characteristics of social determinants, so your physical environment, social and policy circumstances, individual behaviors, are responsible for more than 50% of the variance in health outcomes. So I mentioned some of them before, life expectancy, but also chronic illness, about all of it. That's in contrast to biologic determinants, which, by the way, Stanford built its name after, right? biology, was kind of born here or co-birthed here at Stanford. And healthcare determinants, which is a lot of us do. So that's true at an associative level, but it's a little too simple of an explanation. It's not an explanation, it's an association, it's a correlation. So what I want to talk a little bit about and challenge you guys to think about, engage a little bit in conversation, is what are the mechanisms of health equity? And how does that create a bridge to some of the things you guys might want to do or might be doing this year in design? So again, this is, I gave you the Robert Wood Johnson Foundation, more US-centric definition of a health inequity. Here's the World Health Organization definition. It's a systematic, preventable difference in health status for different populations based on geography, sex, race, ethnicity, or socioeconomic status. I was going to ask you this, but I'll just tell you, and then I'll ask you about the other three things that are hidden in the slide. So usually when I ask an audience what is responsible for this, these people usually say poor access, right? Poor access to what? Drive health inequities. Poor access to housing. What? Housing. What else? Healthy foods. Healthy foods.
Specialists.
Right.
Health education.
Health education.
Education in general.
Education in general.
Time to take care of yourself.
Time to take care of yourself. Okay. Maybe transportation to what? Okay. It's, by the way, fascinating because I set you up with all this health, like social determinants. You were like food and this, maybe actual care, right? Right? Like direct patient care. Good. Anything else? Basic services like water, right? Housing, right? If you take a global group. So our intuition is that what drives all of health inequities is inadequate or inequitable access to all of those things. And we could probably put other things in this, but yeah. It turns out, and why do I know this? Because my mentor says it. No, it comes out of a lot of stuff. Paul Watt, you guys know Paul? The mentor of mine. Brilliant thought leader in equity policy. But he pointed out there are actually three ingredients to any health inequity. And if you lead with nothing else, lead with the wisdom from Paul and not from me. Because this will also, I think, if you really meditate on level of conversation, make you think a little differently about this. So it's two other things. And there's a longer exercise, but this is a short exercise I can do. So it's poor access, not for anybody, but particularly for high-risk population. So think about a problem you're trying to solve for. You guys, you've chosen problems that you're solving for in your groups yet? Give me one. Pediatric asthma. Perfect. Is everybody are all kids at equal risk for asthma? So what do we know about populations that are higher risk for asthma?
Definitely like born prematurely. Like
Okay, so prematurely born infants or children.
Environmental plays a big role. So living in locations with a lot of pollution or poor air quality.
Okay, so people who are living in places with poor air quality. Any other groups that you know that are higher? High smoking. Maybe high smoking prevalence, yeah. The big one, so it's there's little geography to that. Right? So find geographic high-risk populations, you could find medical high-risk populations from preterm birth. Other medical populations we identify by family history for a lot of conditions, so family history of asthma. And also race ethnicity plays a role. Another one of my roommates, I'm going to keep bringing roommates into this. Esteban Gonzalez-Burchard is actually the world's expert on the genomics of asthma. And it turns out that the closer you are to the middle passage from Africa to the US in your genomics, the higher the risk of asthma. So we used to say African Americans, it's actually that. So he's kind of mapped that out pretty well. So there are lots of different ways of defining high risk populations. You know, you'll need to do one for those. But thinking about poor access for the highest risk population, it's a little different than poor access for everybody. And the third one, which in retrospect might be intuitive, but it's not, is to what? To what efficacious technology, right? So if we're talking about asthma, who said healthy foods? So is healthy foods an efficacious technology for asthma? No, not necessarily, not from what we generally know. I mean, it's what will be an efficacious technology for asthma, say? An inhaler, which inhaler?
Like a rescue albuterol.
Rescue albuterol. Okay, knowing the efficacy of that rescue albuterol is a key element in your health equity exploration. And sometimes we forget about that because we think, oh, it's all what Lee was talking about social determinants. But explore that a little bit. I don't have time to do that with you. You might be surprised by how efficacious or non-efficacious that is. Really, really important to do that. And to circle back and find what the highest efficacy technology is for the problem you're trying to solve. Because it's only there, that's the point of the sphere for. I haven't brought this example up before, but I mean, you guys know Paul Farmer is another Paul who wasn't, sadly passed away, but got to know him. In Miami. Paul Farmer drove this model to the hill, right? He said, what's the high efficacy technology for treating HIV/AIDS? It's the latest antiretrovirals. But let's not be, avoid that fact. Let's go into Haiti, let's go into Rwanda and provide those highest efficacy tools to that highest risk population. Just to give you like a flavor for that. And the other reason I do it is because I have in my past and my trainees have wasted our time on this because we're trying to drive better access to something where the efficacy is fairly questionable. I could list lots of these examples. So be very cautious about this when you do design. That's where things explode, okay? Differential access for high-risk population to an efficacious technology. So the reason why, I don't know why I came up with this. My wife said, you need something to emphasize. Okay. So the reason why I point this out is the reverse is also true. And that's what Paul is actually, Wise is written about. Anytime a highly efficacious technology comes out, it almost always introduces a new disparity. Anybody think of a recently highly efficacious technology or medicine that's come out that's been on the front pages of papers? Yes.
Alzheimer's drug?
Alzheimer's drug. We've talked about the efficacy of that. Ozempic is the one I was thinking of. That's a good one we get to. Right? Highly efficacious, reading all the studies, really good at reducing obesity, really good at reducing type 2 diabetes. Who got it first? Who's still getting it first? Really wealthy people, right? Like, look at the map, like Upper East Side of Manhattan. I mean, like literally the ring paper. It introduces disparities. Our job as designers is to think ahead of time to reduce that truism, or at least reduce the time delay there. I'm not going to go into this a lot, but I'm going to say that a lot of this stuff is not new that I'm sharing here. A really important paper, if you're interested in health disparities, a really important monograph actually came out of the Institute of Medicine, now called the National Academies of Science, Engineering and Medicine. Now more than 20 years ago was unequal treatment. And they really talked about this framework in really thoughtful ways and pointed out that what drives these disparities in access for differentially at risk populations to highly efficacious technology is in part at the top patients' preferences and clinical appropriateness, but mainly systems issues and individual issues. Issues that get in the way of that access and real discrimination, sometimes implicit, sometimes explicit. And there have been a lot of studies that have informed that, so we need to be aware of that. So again, to paraphrase Paul and to think about the stuff that drives me and that after my personal experience is greater moral clarity. Any bad health outcome is a tragedy, but a preventable bad outcome might not only be inequitable, unjust. So that kind of drives a lot of my work. A couple quick examples of this from pediatrics, infant mortality. We still in this country have a vast Black-white difference in infant mortality and maternal mortality. Twice as bad for people who self-identify as Black, white in this country. We still don't know all the drivers of it. We have a prematurity research center here that's working hard, using lots of interdisciplinary research to get to the heart of it. And we also have disparities in preterm birth. And we worsen those disparities by introducing an efficacious technology. While I was in medical school called surfactant, that some of you guys may have seen that fluid we deliver via the lungs. That disparity in the receipt of surfactant reduced, but it took about 12 years to reduce. That's an example of how we introduced a disparity in terms of a new intervention. I'm not going to linger too much on this. I just want to say that, I talked about my values before. These are the 3 different areas in which I try to find really tough challenges to design around: epidemiology, public health, and social well-being. In terms of epidemiology, I pay attention particularly to people with chronic illness, and in my world, children with special healthcare needs, and the fact that that's roughly the medically complex population, about 5% of the population, about 30% are getting their health needs met. I think about larger issues and public policy as informing this work. So 1 in 4, and 1 in 4, and now 1 in 5 US children live in poverty. 4 children live in poverty. Most US children are covered by Medicaid. So we think about Medicaid as a driver of a lot of changes. So when I bring challenges to our design work, I often reach out to our Medicaid managed care partners or federal agencies concerned with Medicaid and say, what problems are you trying to solve? And then for social well-being, this is the link to some of the work I've been doing in literacy and literacy lens. 30% of US adults have limited literacy or limited English proficiency. And yet more and more of healthcare delivery and even public health is sort of consumer-centered, with a greater burden of health information complexity and even misinformation. We're creating this like information jungle for folks to navigate that oftentimes they're not capable of navigating very well. So I want to, what's that, 20 minutes, perfect time. So I want to give you an example of this. This is an example. We have different tools to assess folks' health literacy, their ability to navigate health information. And this is an example of a question from one of the tools we use in our pediatric health assessment tool. Anybody here have kids? Imagine your kid come in with an ear infection, common thing, not as common as it used to be. We diagnose an ear infection and we give you this prescription for amoxicillin. Pharmacist gives you this, and that's the dosing syringe on the right-hand side. So how would somebody who's not a kid, somewhere in this middle, want to tell me where would you fill the bottle? This requires you to get up and walk up to the front. And if you don't do that, I'm going to ask one of the fellows to designate another fellow wants to come up to the volunteer yourself before I. Oh, thank you very much. Just come up and.
Where on the syringe?
Yeah, where on the syringe would you fill it?
Yeah, so 2.5.
Right there. How you guys doing? Do you agree with her? Great. Okay, wonderful. So what's your name, by the way?
Shireen.
Shireen, thank you. Applause for Shireen. Okay, so Shireen has good, or what we say, adequate, we don't know, health literacy. It required you to find in what we call gobbledygook, that's an actual term in health literacy, gobbledygook, the actual operational information. Do a little numeracy and figure out what 2.5 mLs, and then line that with. So the real question is, in a population-based study, we had nearly 400 families involved in this, different socioeconomic backgrounds, pretty diverse, 6 different sites. About what proportion of them answered this question correct? Huh? Half? We got half? 33%. Everybody, Jorge, I was real impressed that you did that because you're going against, everybody knows the right answer is always C. Like when in doubt, the answer is C. But it also aligns with what I mentioned before, that about a third of US adults have below basic or basic health literacy skills. And those are some examples of that: understanding employment slip, the growth chart, et cetera. We've done a lot of work using assessments of this that the the Department of U.S. Department of Education has put out. They survey more than 15,000 U.S. adults to get this kind of data. Europe does something similar. It's pretty similar in Europe. But here's the other fact, and this hasn't changed much despite a lot of our efforts. But if grade level is not really a great way of doing this. Educators don't like this. Health literacy people don't like this. But for a general audience, I use this. Roughly the median reading grade level of U.S. adults is around 6th grade level. Almost everything we put out in the health and public health space is at a more complex level than that, both the text and the visuals of that. My colleague at Johns Hopkins, Deborah Roeder, calls this public health malpractice, which is always good to put up on a slide when people are drifting away. Medical malpractice. So in other words, we would never do. We would never do that with anything else. Give something to somebody that they know. But this is why I find it to be a very useful tool, language and literacy, to think about or to stress test some of the designs that we're doing. And the other reason I find that is because in a series of both experimental evidence and more observational evidence, we know that low health literacy is associated with poor health outcomes, both in maternal and child health, where I work, and in adult health, largely around behaviors that are sensitive to really being able to know what you have to do, discretionary behaviors. So this is one model for a lens for designing for health equity using literacy as a basis. And you can see a little bit about what that looks like. Health system, education system, culture, and society, all informing what we have as health literacy and what we look at it. So I'm going to very quickly talk through a few things because I want to get to our conversation. So some of this you can intuit, but I use that as a challenge for you and things that we can call on if I'm working with you guys individually or in some of your teams, thinking about where there might be opportunities for health literacy to come in. So we can think about product design opportunities for that, systems design opportunities for using literacy sensitive tools to improve a design of any system or service. See some of these right here, but I'll just color coded BMI charts. Intuitive. I don't need to explain to you that except to say on the left, those are the paper charts we used to do in the before. On the right is the ones we'd love to put in the EMR. Are they in the EMR yet? No, don't ask me why. Implementation problems, right? Implementation science. Color-coded results for your labs. Right now, you kind of just get this red number and then you call your doctor and it's freaking out, right? But red, yellow, and green, where it tells you a little bit about what each one. Same thing for liquid. We've done a lot of work in pediatrics on liquid medication dosing. Different versions. We wouldn't do both of these, but different versions of tools that make it easier for people to dose medication more clearly. This comes out of that green light study that Chris had mentioned before that I've been working on for 15 or 20 years. Literally drew the study up on the back of an envelope at the back of a meeting once, and it's been really productive. We're working in 6 different sites across 5 different states. And we've co-designed these materials with families from lots of different backgrounds. So it's not just color-coded appropriately and low literacy, but also even the foods chosen for these different booklets that we provide are very culturally appropriate to different families in different areas. And we've tested it. As a result, we think of that. Not only did we see real results on reducing obesity risk in early childhood, but greater results for families in who have low health literacy, or who are at higher risk, right, or have limited English proficiency. So that was kind of exciting. We haven't, I can't put up the next slide that I want to put up for you because it's cooking at JAMA right now. We haven't added on designed intervention, working with low-income populations for text messaging boost to this intervention, really looking at how text messaging can help sustain them. Okay. So now I'm going to shift to a little bit about what we're doing at the D School, because that's also what it's asked me to do. So at the D School every year for a quarter class, we have a different challenge. This challenge this fall is going to be around navigating to needed services for kids with special health needs. So we bring somebody, in this case, we'll bring somebody from a federal agency to provide this challenge. And we ask students, much as the Biodesign fellows are asked to do here, to apply human-centered design to craft a service or system that addresses this challenge. We very much put it though through that framework of health equity that I talked about before, really investigating what's the efficacious technology here we're thinking about, that we're trying to get to. Who are the high risk populations, really trying to understand them, and then maybe backing into some of the issues of access. Always with patients or their families as co-designers. So this is an example of the course journey. CJ would probably say, no, we have a kind of different course journey this year, but it's roughly like this: building community, getting to know one another at the beginning. Doing our first challenge might have nothing to do with health. We're thinking this fall, our first challenge is going to have to do with food services on campus. So, something that we can all relate to. So that when we then move to our main health challenge, we bring in patients either from my clinic or my colleagues' clinics, and really are asking for their time as co-designers. We can really be sensitive to what it means to reflect and listen. So I want to have a little bit of a conversation with you about what this field research looks like. We talk a lot about the ethics of working with families and patients from vulnerable backgrounds, and how we do this in the most respectful way, how we build trust, because a lot of the work in design, as it is in health literacy, as it is in good health research, is about building and sustaining trust through conferring deep respect. Those are two big words: trust and respect. And that's what I want to talk to you guys about iteratively and how you can build this into your own work. Do a lot of design research in the field, bring that synthesis back into the classroom, and co-design ideas with the patients and families, and they love giving critiques to our students about why that's not going to work, my context, and so forth. So here are some photos of this in the middle, some of the families and patients who have dedicated their time. We do field trips out to community health centers. This is some photos in the corners from the community health centers. We get to come back to, it's not quite as clean and beautiful as Biodesign, but peaceful. We got the whiteboard set up and do a lot of journey mapping and ideating together. And here has been my experience time, as I mentioned before, from the very first time I did this D school, and from what I've learned from folks at Biodesign, I find that the kind of creativity that comes with good centered design is nothing short of remarkable. As a clinician, now as a patient, even more so. And why? Because if you do it right and you're really listening to patients, you're going to come up with key insights. So I want to share these key insights because they kind of look almost like cliches there. But I want to explain to you how this hit me. So I brought families that I thought I knew super well. It's just going to be easy peasy. I knew what to do. Known them, some of them for 5 years, some of them for 10 years. I knew grandparents' names. They all had my cell phone numbers. But the students really listened, and they were like, what are these families for? And this, by the way, some of these insights in some version always come back. They need people dealing with, at least with chronic health conditions, need help with the little things at home that are most often not met. They need to achieve goals for themselves or their child that are not medical. Yes, all of us want to be respected and validated as human beings and find that the healthcare system is that. Despite the way we look, I'm speaking for patients, now as a patient, we want to be accepted as normal. And sometimes we just want a break. And around each one of these, you can't really design for all of them at once. Around each one of these could be a brilliant design solution. And so I'm just going to give you a few from, I don't know, 2 or 3 years of doing this. Reach out and read, accepted, but the other 4. So the top one, I remember this from the first class, was a design called The Village, like a wedding registry for post-NICU support. So it's the idea of like dealing with those little things at home. What if we just allowed a community to set up to help people with whatever they needed at home if they're not medical? You know, bringing a little baby into a very crowded apartment. Here's another one called Culture Shift. The idea was to give ID tags, because I would be running to class all the time. I don't have that, but I'd be wearing my medical tag. And this one, design student said, well, there's kind of an authority that comes with it. Why not give that authority to people who are professional patients? I mean, the patients that I come in who are navigating the system, give them that authority. Let's give them that tag. and let them do certain things with that. Certainly at least 20% off at the cafeteria, right? But also, so that the emergency department knows when they come in with that tag, they don't have to go through the same checklist. Want to ask for some expertise. Anyway, so those are a couple ideas. There were some added on attributes to Greenlight that I described before. And Krista mentioned some of the stuff that we're doing with funding from FDA CERC to create virtual pharmacists for adolescents with chronic illness, which was really listening to and elevating youth voice. I could go on and on. I mean, each one of these. What we don't have is sustained funding to keep this going. So one of the other things that I'm looking out for doing and saying as well, is building a health equity design consortium. People have been reaching out from other parts of the country to do this as well. What does that mean? So as these ideas percolate, that we really have a more continuous place to take them. Maybe physical space, it could be here, it could be at the school. It's going to give me a tour around here. But these are the general players that we think we need. We certainly need you guys as D school students. I just realized I misspelled industry partners before I had asked for industry partners. I should probably spell that correctly. We need researchers, clinicians, patients, and families. So stuff on the left-hand side we've got. The stuff on the right-hand side we're in the process of nurturing. So we want a core team. We want designers, videographers, people who can kind of level set things and kind of help you tell these stories on a continuous basis. And industry partners who are serious about testing your prototypes. That's actually a big, you'll see, friction point, as you guys do. People say they want to do it, but when it really comes to shove, that's where it breaks down. So I want to I want to suggest these three messages and talk a little bit about these. From my limited experience, applying the health equity framework of access, risk, and efficacy works. If you forget risk and efficacy, you're only getting a piece of the picture. Co-designing around key insights and meaningful moments, which I didn't talk about, we can talk a little bit, really works. And staying humble is super important. I always need to check my privilege at the beginning and check at the end. I'm constantly trying to check that and really looking for and listening for insights. That's why I'm in this room. Not to impart knowledge to you, actually just to get to know you, show you a little bit of myself, so that when we interact and before you kind of heard this stuff before, I want to hear from you guys. I want to hear from patients, healthcare providers, people that you're listening to, and not just listening to. The other thing I learned, who need learners, observe. Oftentimes, those little things that you observe, like that ID card that I mentioned, that student observed, that are the triggers, and it can sometimes be as mundane as that. They're the triggers to the key insights. Once you start over designing, complexifying things, you might be losing one of the key observations. So anyway, so those are my main comments. I hope we have some time, discussions, some questions. I have questions for you guys, but why don't we start with questions you guys have? Start.
Hi, my name is Anastasia. I'm a second-year fellow. I used to be a biodesign fellow last year. And we're working in oncology, and our team really did notice the impact of health literacy and translation problems in clinicians. So we spent quite some time working around this need. And although it was very clear how it affected the patients and how they perceived the trust towards the healthcare system, we struggled creating compelling business model, let's say, for who is going to pay and see the outcomes for health literacy. So I don't know if you have any pointers on how we can build something that shows that improving health literacy directly improves health outcomes. Yeah. And all these co-founding factors that also play. Yeah. So in case there are people online who can hear this, so and also I teach back. So that's what we do. So what I hearing your question, and remind me your name again? Anastasia. Anastasia. Your question is about how we create a business model for health equity or even health literacy, right? Thank you for asking that. But when I moved back here from Miami, actually, patients were like, "Why are you moving?" I said, "I'm moving out here to bend 1% of the minds and 1% of the money from Silicon Valley to issues of health equity." I'm still working on that business model. I don't know that I have an answer for you, except to give you a couple of examples.
Oncology and surgery is where I think health literacy has really tried to prove business model. In surgery, they've actually proven, and there's some good studies in this, that a literacy centered approach reduces canceled surgeries. About surgery, surgeons, if you lose that OR space, that's a big, anybody from the surgeon, forget the surgeon, the COO of the hospital or the CFO gets that. So bringing those data up front and center, we think is part of the solution for that. But you're right, and in oncology, similar things, right? You lose that space for the infusion center. If somebody comes in, they haven't gotten their labs ahead of time, that sort of thing. It's really tough. So since I don't have the answer to you, what I would suggest is we host a few hospital COOs here, CFOs here. I'm also doing research with the Immigration Policy Lab on the language part of this, trying to understand what the I'll just be honest with you. I think that's why I'm here, is to help figure out how to build. The only other thing I could say is if you can say, well, that helped me design a better, whatever it is, that also will help us overall.
May also have questions
Oh,
online.
questions online. Yeah, but we have one here. If you have questions online, maybe write them in. And,
My name is Marissa. I am an innovation fellow this year, and you talked a little bit about needing to preempt introduction of the efficacious solution.
Yeah.
Do you have any examples of how to do that?
Preempt the, you talked about efficacy?
If you're introducing an
For highly efficacious.
anticipate the inequity.
Well, the first thing is awareness and intention, so that we're even answering this question. But yeah, I can give you some examples from our own lived experience. The COVID vaccines, I'll never forget when they came out. And all of us, by the way, all the experts around here were wrong one time after another. How long was it going to take for them to come out? How efficacious were they going to be? All the people I knew, don't forget me, were experts in vaccine development. It's going to take a year and a half, and they were going to be 60% effective. Well, it took 6 months. They were like 90% plus effective. And I remember in the moment, I was like, oh darn, I'm kind of a middle management person, but I'm really worried about this. So I saw both things happen. I saw inequities open up, and I saw people getting on top of them so they wouldn't. And this is just from my little glimmer of it. Others can tell their own stories. So on the global sphere, I saw them, right? Sure enough. It wasn't just, in the full South, it was later to get some of these vaccines and much later to get the more highly efficacious vaccines. And in parts of the US, including very locally, I saw people working as all get out to make sure that those vaccines got to the highest risk people. So I'm going to tell you a somewhat local and a hyper local example. Somewhat local example is East San Jose. Kind of like I was talking about East Palo Alto before, a very low income area, very high risk area, and was known to be high risk for COVID, right? Different, right? Older people, obese people. They got those vaccines there. And if you actually look back at the story, and I know Sarah Cody, the director of the health department, was very involved in this, they made sure that those vaccines, that was part of their distribution plan. They got there, that was every step along the way, that was the intention. Stanford Healthcare had the right idea. They had all the algorithms down. They did the same thing at Stanford Healthcare. And you know who popped up being high risk? There were people in the adult ICUs, but they were also all the food workers and the cleaning staff. They made sure they got them. You know who they left off the list? The trainees, the rep down. You might, if you guys were around, the residents. So, who, by the way, on the algorithm were kind of medium risk or whatever, but they were kind of, it depends on, they weren't the highest risk group, it was the other groups. But those are examples of that. They did that. And by the way, because they left off that one higher risk group, the house staff, protests, people around here, local media didn't go so well. Almost did it right. Does that help? Yeah. Okay, those are some examples. So sometimes it's around the implementation side, but implementation is design. So I think that's part of the way to do it. The only other thing I'll say is I could probably think of some other examples. I certainly can. Health literacy we can talk about later. In the design process, same thing. If you're highest risk group is more likely to be immigrant families and you're designing it first in English, deciding you're going to translate it later. That's a common mistake I see people. So that's another way. And I could go on and on. Hope that's helpful. Yeah.
So
And it'll go on.
as we go through this process, we're gonna have like experts in like MBA and reimbursement, stuff like that to help us. What are some practical ways or like resources that you would recommend that we incorporate to make sure that we're thinking about this throughout the process? Like, are there people within hospital systems that are generally good to approach, or like?
Yeah, so I'm gonna ask some other folks, Sam, to make sure that I provide these for you. So there, I think first to say that there are things that probably we should develop into a toolkit for equitable design, and that don't all come from me, other people. Certainly in health literacy, there's a great health literacy toolkit that HRQ has developed. I want you guys to have because I think it'll help. In terms of people, it's really that deep listening to folks from high-risk communities for your work. Sian was saying that some of you guys are going to be going to Francisco Tenderloin, which might be, I mean, it's a high-risk community, but it might not be for your work, right? So finding the time to go and listen to people in high-risk communities for the work or the problem that you're talking about is really important. For some reason, the work role of 3 is whether it works for me. If you go once, you're not going to get it. You kind of have to know that you're going back at least twice, listening at 2 more times, listening to the same communities, observing. I don't know if that's helpful. I can't emphasize that enough. Just to look for different things, because right now, you know, your team got creative teams, probably diverse backgrounds. You're popcorning all kinds of cool ideas. You want those stakeholders that are outside of the natural room or this building to kind of just say to you, practically that's not going to work, or just so that you can have in your mind personas from the real highest risk populations that you want to reach. I mean, I still think that's why I'm here, is just to emphasize that we need to figure out how to help bridge those experiences into the design. I don't know if that helps, but that's probably what I do. And then there are other resources. There's actually other people who have developed, like I said, toolkits for equitable design, actually beyond healthcare. They're really cool, but I found out through Design Wednesday, certainly. Other questions online? Yeah. Okay, but one question for anything for online? Okay, yes, we are at time. I want to let you guys get back to your regularly scheduled activities, but thank you so much for your time. This has been valuable.
Thank you for so graciously sharing your time, your experience of yourself in the space. It was really wonderful having you here. I think what really stood out to me is just how we're very good at involving patients in an informational way, but I love the fact that you really co-design with the people that you care about and care with. And that really struck me, that you take completely different outcomes when you invite patients to share their lived experience as designers and create a design space instead of a transactional information space. And I hope that's something that at Biodesign we can continue to learn from you and the incredible work that your team is doing at the D School. And I do hope that we will continue this conversation and that this won't be the last opportunity we have to learn from you and with you. And thank you to everyone who was able to join online. We hope you found this useful. We'll be having another brown bag. The advert to here. Our next one is with Professor Sarah Hooper, who'll be talking to us a little bit about domestic inequity and why it is that certain states have great outcomes, other states don't. We've all seen the map with the different colors and the one that Lee showed us now, but why is it that that's the case? She's actually the professor of Health Equity and Legal Lab down in SF at UC Hastings. That'll be happening for those of you joining us live on September the 18th from 1:15 to 2:15. And then in October, we'll get to hear from our very own Krista Donaldson, who actually get a chance to share about her work in Equalize Health and her Brilliance product, which was a phototherapy device designed for her resource settings. And she's going to talk to you about important design lessons that she learned, trying to bring technology to places where there weren't good solutions that were contextually appropriate available. And that'll be on October 24th, from 2:30 to 3:30. So I hope you found this useful. Thank you for those of you joining online. We do have a recording if anyone would like to get hold of that. And we always welcome your feedback as to speaker suggestions you'd love to hear or other additions. Please do enjoy some food. And thank you again to Lee, and thank you to Krista and Antje and Deja for all the logistics for the event. Thanks, everyone.